Welcome back to the deep dive. Today, we are zooming in literally. We're adjusting the microscope focus and looking at a battle that's been raging since the dawn of humanity.
It really has.
We're leaving the clusters of staph behind, and we are looking for chains.
Chains and pairs. That is the visual anchor for today. I mean, if staph is the bunch of grapes, then strep is the string of pearls.
I like that. Or, given how dangerous some of these are, maybe a string of grenades.
That's probably more accurate for some of them, yeah.
We're diving into Murray's medical microbiology, specifically Chapter 19, and we're going to be pulling in some key biochemical data from Jowett's Chapter 14 to, round things out. Our mission today is to decode the genus Streptococcus and their tough-as-nails cousins, the Enterococcus.
And looking at the outline, this isn't just a list of bugs. This is a whole spectrum of aggression.
It really is.
It absolutely is.
Yeah.
You've got the aggressor in Group A strep, which uses, brute force and toxins. Then you have the silent assassin in Group B, targeting the most vulnerable.
The newborns.
Exactly. Then you have the saboteur in the Viridans group, rotting your teeth and heart valves really slowly. And then, as you said, the survivor, Enterococcus, which just refuses to die.
So before we meet this whole cast of characters, we need the map. If I'm a microbiologist and I have a gram-positive coccus on my plate, how do I know I'm not dealing with staph? Because staph is also a gram-positive coccus.
Right. That's the first fork in the road. And it's the catalase test. This is absolutely fundamental.
Okay.
You take a colony, you add a drop of hydrogen peroxide, and you just watch.
And what are we looking for?
Bubbles. If it bubbles vigorously, that's staph. Staph has the enzyme catalase, which, it neutralizes peroxide. It's a defense mechanism against our own neutrophils.
So bubbles equals staph. Easy enough.
Correct. But if you see no bubbles, if it just sort of sits there looking inert, that is catalase negative.
And that's our guy.
That is your Streptococcus or Enterococcus. They don't have that specific enzyme.
Okay, so we are officially in the no bubbles zone. Now, Murray describes a really specific way to classify these, effectively a traffic light system based on how they eat blood.
Yes, the hemolysis classification.
This sounds important.
This is the mental framework you need to hold on to for this entire deep dive.
Yeah.
Imagine a blood agar plate. It's red because it's filled with sheep red blood cells. We streak the bacteria on it and see what happens.
Okay.
First, you have beta hemolysis. This is the green light for aggressive infection, though strangely, the plate doesn't turn green.
Ah, right. Beta means what exactly?
Beta means complete lysis, total destruction.
So it's just wiping out the red blood cells.
Completely. The bacteria produce enzymes, we call them streptolysins, that totally destroy the red blood cells. If you hold the plate up to the light, you see a clear, transparent halo around the colony.
You can literally see through it.
You could read a newspaper through it, yeah.
So beta is clear. It's a total wipeout. Who are the beta offenders?
The big guns. Group A strep, which is Streptococcus pyogenes, and Group B strep, Streptococcus agalactiae.
Okay.
There are also some groups C and G, but really A and B are the headlines.
Got it. Okay, next on the traffic light.
Next is alpha-haemolysis. This is partial lysis. The bacteria produce hydrogen peroxide, which it oxidizes the hemoglobin inside the red blood cell.
So it's not blowing them up, it's changing them.
Exactly, it's changing them chemically. It turns the hemoglobin into methemoglobin. And methemoglobin has this distinct greenish color. So on the plate, you see a green, kind of bruised-looking halo around the colony.
Okay, so green means alpha. And the main characters here?
That would be Streptococcus pneumonia, the pneumococcus, and the whole Viridans group of Streptococci.
Right. And finally?
Finally, we have gamma hemolysis, which is actually a bit of a misnomer because it really means no hemolysis.
Nothing happens.
Nothing. The bacteria grow, but the agar stays red. They don't phenolize the cells at all. This is typical of the Enterococcus species, which, these we call Group D strep.
So, to recap, beta is clear, a total wipeout. Alpha is green, a partial bruised look, and gamma is red, or rather just no change. That's our taxonomy map.
That's your map.
Now let's get into the specific Lancefield groupings. This was developed by Rebecca Lancefield way back in the 1930s, right?
Slightly.
She was using antibodies to identify specific carbohydrates in the cell wall.
Yes, the Lancefield grouping. It's a fantastic system, primarily used for the beta hemolytic streps. So Group A has the Group A antigen, which is a dimer of N-acetylglucosamine and rhamnose.
Okay.
And Group B has the Group B antigen, and so on. It's a serologic classification, but it matches the biological behavior of these organisms perfectly.
So it's not just an arbitrary label. It actually tells you something about how the bug is going to behave.
It tells you a lot.
Let's move to the first major section of our outline then, the aggressor. Streptococcus pyogenes, group A strep.
The prototype pathogen.
This bug seems to have a toolkit for everything. I mean, it can infect the throat, the skin, the blood, the fascia. It's everywhere.
It is the absolute prototype of a human pathogen.
Yeah.
And to really understand it, you have to look at its armor. The most famous piece of armor is the M protein.
I always visualize this like a spiky coat on the surface of the bacteria. Murray makes a big deal about this being the general of the virulence factors.
It really is. The M protein is anchored way down in the cell membrane, and it protrudes right out through the cell wall. Its main job is to be anti-phagocytic.
So it stops our immune cells from eating it. How?
Well, normally your immune system tags bacteria with a complement protein called C3b. You can think of it like putting a little eat me sign on the bacteria for the neutrophils to see.
Okay, a homing beacon for phagocytes.
Exactly. And the M protein acts like a jammer, or maybe a bouncer, like you said. It binds to a host protein called factor H, and factor H's job is to degrade C3b.
So the eat me sign gets ripped off before anyone sees it.
It gets ripped right off. The phagocytes, the neutrophils, they just swim right past it. They literally don't see it as a target.
That's clever. Now, Murray emphasizes a really critical distinction here. Class I versus class II M proteins.
Yes, and this is a huge deal. You have to know this for exams.
I recall this being a major differentiator for the post-infectious sequelae.
Exactly. Strains with class I M proteins have parts that share antigens that mimic our own heart tissue, specifically cardiac myosin.
Oh, wow.
And this is the setup for rheumatic fever. If you get infected with a class I strain, your immune system might get confused later on and attack your own heart valves. Class II strains, on the other hand, generally do not cause rheumatic fever.
That molecular mimicry is a terrifying concept. We'll deep dive into rheumatic fever in a moment, but the bacteria is effectively wearing a mask that looks like your own heart.
That's a great way to put it.
Speaking of masks, what about the capsule? Murray calls it a wolf in sheep's clothing.
It's brilliant camouflage. The capsule of group A strep is made of hyaluronic acid.
Okay, now think about where you find hyaluronic acid in the human body.
It's everywhere. Connective tissue, joints, the vitreous humor of the eye, skin. It's a fundamental building block of us.
Exactly. So when the immune system bumps into this capsule, its chemical signature says, oh, nothing to see here. This is just self-tissue.
It creates chemical invisibility. It's not just a shield, it's a full-on disguise.
So we've got the M protein fighting off phagocytes and a capsule that makes it invisible. Then Murray lists C5a peptidase.
Right. Another piece of the puzzle. C5a is the homing beacon for neutrophils. It's a powerful chemoattractant.
So it calls for backup.
It's the 911 call of the immune system. When an infection starts, C5a is released to call the police the neutrophils. And this bacteria produces an enzyme, C5a peptidase, that specifically seeks out and degrades that C5a protein.
It cuts the phone line?
It cuts the phone line so help can't arrive. It's a comprehensive strategy. Hide, jam the signal, and cut the communication.
But sometimes it doesn't just hide. It attacks. I'm looking at the list of toxins, the SPE toxins.
Streptococcal paragenic aerotoxins. This is the heavy artillery. These are superantigens.
And a superantigen is bad because why?
To understand why that's so bad, you have to remember how T cells normally work. Usually a T cell only activates if it sees a very specific antigen presented in a very specific way by an antigen-presenting cell. It's a lock and key mechanism.
That's highly specific.
Incredibly specific. Only maybe 1 in 10,000 T cells might respond to a given infection. This prevents the immune system from, going nuclear on a minor threat.
Okay, makes sense.
But a superantigen doesn't care about the lock and key, like a master key or maybe more like a crowbar. It grabs the T cell receptor and the MHC molecule and just forces them together from the outside.
It hotwires the ignition.
Perfect. It hotwires the immune system. So instead of 0.01% of your T cells activating, you suddenly get 20% of them activating all at once.
And when 20% of your T cells scream at the same time.
You get a cytokine storm, a massive, overwhelming release of IL-1, TNF-alpha, interferon gamma, and this leads directly to shock, high fever, and multi-organ failure.
And this is the mechanism behind streptococcal toxic shock syndrome.
And the rash of scarlet fever. And a key point from Murray here. The bacteria doesn't inherently own these genes.
Right, they get them from somewhere else.
They're brought in by a bacteriophage, a virus that infects the bacteria. This process is called lysogenic conversion.
So a non-toxic strep strain can literally catch a cold, a virus, and suddenly it becomes a killer capable of causing toxic shock.
That is wild.
This horizontal gene transfer in real time.
Let's talk about the clinical presentation. We can divide these into suppurative, meaning pus-forming, and non-suppurative, the sequelae.
Right.
Pharyngitis strep throat is the most common one. But clinically, how do we distinguish this from a viral sore throat, which is way more common?
It's all about probability, not certainty, but there are definite clues. Strep pharyngitis is usually a very sudden onset.
Okay.
And you usually don't get a cough, chorea, or a runny nose.
Oh, interesting. So the absence of cold symptoms is a clue. It's a big clue. Those are typically viral signs. With strep, you're thinking painful swallowing, a high fever, and often you'll see exudate, those white pus patches on the tonsils. And if you feel their neck, those anterior cervical lymph nodes will be swollen and tender.
And if that strain of strep happens to have the SPE toxin we just talked about,
Then you get scarlet fever. It's strep throat plus a systemic reaction from that superantigen.
okay, and for the exams, you need to memorize the visual anchors for this.
Absolutely. First, the strawberry tongue. It starts with a thick white coat and red swollen papillae poking through. That's the white strawberry tongue. Then the coat peels off after a couple of days, leaving a raw, bright red surface. That's the red strawberry tongue.
Okay, strawberry tongue. What else?
Second, circummoral pallor. The patient's face is flushed and red, but the area immediately around the mouth stays pale. It looks like they're wearing a pale mask just around their lips.
I can picture that. And the rash itself.
The rash has two key features. One is Pastia's lines. The rash is darker and more intense in the skin folds, the armpits, the groin, the creases of the elbows.
And the texture.
This is the classic SBA buzzword. It feels like sandpaper.
Yeah.
It's a fine papular rash. It blanches with pressure, and it characteristically spares the palms and soles.
Sandpaper rash, strawberry tongue, circummoral pallor. That is the scarlet fever triad.
You see that, you should be thinking group A strep.
Now, let's move from the throat to the skin. Murray lists impetigo, erysipelas, and cellulitis. Impetigo is the really superficial one, right? The honey-crusted lesions, highly contagious in kids.
Correct. Very superficial.
But the exam favorite is always differentiating erysipelas from cellulitis. They can both just look like a red infected leg.
It's all about the anatomy. It's about how deep the infection goes in the skin layers.
Okay, break that down.
Erysipelas is superficial. It involves the upper dermis and the superficial lymphatics. Because it's so high up in the skin, the fluid accumulation, the edema, makes the plaque raise.
So it's a raised lesion?
It's raised, and crucially, there is a sharp line between the sick skin and the healthy skin. You could literally trace the border with a pen. It is clearly demarcated.
Okay, sharp border, raised plaque equals erysipelas. So it's cellulitis.
Cellulitis is deeper. It's down in the deep dermis and the subcutaneous fat. Because it's so deep, the redness and the swelling kind of diffuse out. The border is indistinct. You can't tell exactly where the red stops and the normal skin begins.
This is blurry.
It's blurry. So to summarize, erysipelas, sharp, raised, superficial. Cellulitis, Becoles, blurry, flatter, and deep.
And then the absolute disaster scenario, necrotizing fasciitis.
Streptococcal gangrene, the flesh-eating disease. This is a true surgical emergency.
How does this happen?
This happens when the bacteria get access to the fascial planes. These are the thin, tough connective tissue highways that separate your muscle groups.
Right.
And remember those enzymes we talked about? Streptokinase, which dissolves clots, and hyaluronidase, which dissolves connective tissue. The bacteria use these to literally liquefy the fascia and travel at incredible speed along the muscle.
So it spreads under the skin.
Way under the skin. And what's the clinical tell? Because early on, the skin itself might not look that bad.
That is the trap. The skin might just look a little bit red or maybe have a small blister, a bulla, but the patient is in agony.
Right.
The classic description you have to remember is pain out of proportion to physical exam. So if you touch the leg and the patient screams, but it just looks like a mild sunburn, you have to be worried.
You have to think neck vac. You have to get a surgeon involved immediately. You cannot cure this with antibiotics alone. You have to surgically debride. You have to cut out all the dead tissue.
Time is fascia, as the surgeons say.
Exactly.
Okay, so that's the active pus-forming infection. But strep has this nasty habit of causing trouble long after it's gone. The non-suppurative sequelae.
The immunological ghosts of the infection.
Let's unpack rheumatic fever. This is a huge topic in global health.
It is, though thankfully much rarer in the West now.
Yeah.
This is a classic autoimmune response. We talked about the class IM protein mimicking heart myosin.
Yeah.
So a child gets strep throat. They might get treated, they might not, they recover, they feel fine.
Right.
But 2 to 3 weeks later, the antibodies their body made to fight the strep reach their peak levels. These antibodies start circulating, and they latch on to the mitral valve or the aortic valve of the heart.
Because it looks like the M protein.
It looks just enough like the M protein to be a target. And this antibody binding induces a massive inflammatory response carditis.
And this leads to the Jones criteria for diagnosis.
Right. To diagnose acute rheumatic fever, you need evidence of a recent strep infection, like a positive ASO titer, plus a combination of the Jones criteria.
And the mnemonic helps here.
J is for joints. This is a classic migrating polyarthritis. One knee swells up and it's painful, then it gets better, and then the elbow swells up. It moves around.
Yep.
Oh, it looks like a heart. That's for pancreatitis. Inflammation of all three layers of the heart: pericardium, myocardium, and endocardium. This is what kills you acutely or leaves you with permanent valve damage like mitral stenosis down the road.
What's N?
N for nodules, little subcutaneous nodules over bony prominences like the elbows or the spine.
E.
E for erythema marginatum. This is a weird, ring-like, serpiginous rash that spreads outwards.
And finally, S.
S for Sydenham's chorea. This is also called St. Vitus's dance. It's rapid, involuntary, jerky movements, especially of the face and hands. It's a very striking neurological finding.
Okay, here is the million-dollar question for any exam. Does rheumatic fever follow skin infections like impetigo?
No, absolutely not. Never.
That's a hard and fast rule.
It is a hard rule. Rheumatic fever only follows pharyngitis. We don't fully understand why. It might be related to the specific M protein types that infect the throat versus the skin, or something about the lymphatic drainage of the pharynx. But for the exam, sore throat leads to rheumatic fever. Skin infection does not.
Okay, let's contrast that with the other major sequela, acute glomerulonephritis, AGN.
This is a totally different mechanism. This is type 3 hypersensitivity.
Okay, not molecular mimicry.
Not mimicry. Here, the body makes antibodies. They bind to leftover strep antigens that are still circulating in the blood, and they form these little immune complexes.
Clumps of antibody and antigen.
Exactly, little clumps. And these clumps travel to the kidneys, and they get stuck in the glomerular filter. They physically clog the drain, and in doing so, they attract complement and neutrophils, causing massive inflammation.
The symptoms that result from that?
The kidney filter breaks down, so you get blood in the urine hematuria, which is classically described as Coca-Cola colored urine or decolored urine.
Right.
And the kidneys can't get rid of salt and water properly, leading to hypertension and periorbital edema, which is that classic puffiness around the eyes, especially in the morning.
And the big question, does AGN follow throat infection, skin infection, or both?
It follows both.
Yeah.
And that is the key differentiator you have to remember.
So you can get AGN after strep throat or R after impetigo.
Correct. So let's put it all together. Rheumatic fever follows throat only, and the mechanism is molecular mimicry, a type 2 hypersensitivity.
Okay.
Glomerulonephritis follows throat or skin, and the mechanism is immune complex deposition, a type 3 hypersensitivity.
That is absolute gold for an exam. Now, how do we diagnose these? The bacteria are usually long gone by the time these symptoms start, so a culture is useless. We have to use serology.
Correct.
We mentioned the ASO titer earlier for anti-streptolation O.
Right. ASO is a great test for confirming a recent case of strep pharyngitis. So it's very useful for working up suspected rheumatic fever.
But what about for AGN, especially if it followed a skin infection?
There's a catch. If you are looking for evidence of a past skin infection, the ASO titer is often falsely negative.
Why is that?
Because cholesterol and other lipids that are present in the skin neutralize the streptolysin O toxin before the immune system can really see it to make a robust antibody response.
So the antibody levels just don't go up?
They don't go up reliably. So if you suspect AGN after a skin infection, do not order an ASO. You order an anti-DNase B titer. DNase B is another enzyme made by the strep, and it's highly immunogenic after both throat and skin infections.
Pro tip, anti-DNase B for kidney issues after a skin infection. Okay, let's pause on the aggressor. That was a lot.
It's a formidable bug.
Let's pivot to section 2, the neonatal threat. Group B strep, Streptococcus agalaxiae. This bug is less flashy than Group A, but in the right context, it's just as deadly.
Yes. Group B is the primary enemy of the newborn infant.
Let's start with lab ID. It is also beta hemolytic, right?
It is, but the zone is narrow. It's just a little sliver of clarity around the colony, not that big wide ring you see with Group A.
And what's the key antibiotic test?
It is bacitracin resistant. Group A is sensitive, Group B is resistant. The mnemonic I've heard is Group A answers to bacitracin, Group B blocks it.
I like that. Now, Jazz really emphasizes the CAM-MP test. This is a classic visual in the microlab.
It is. The CAM-MP test detects a specific protein called CAMP-P factor that's produced by Group B strep.
And how does it work?
You streak a line of Staphylococcus aureus down the center of a blood agar plate. Staph produces a beta-haemolysin of its own.
Okay.
Then you streak your unknown bacteria, your suspected Group B strep, perpendicular to it, coming really close but not quite touching.
And if it's Group B?
Where the two bacterial zones of influence meet, the CAM-P factor from the Group B synergizes with the Staph haemolysin to create this massive flare of enhanced hemolysis. It looks exactly like an arrowhead pointing right at the staph line.
So an arrowhead of hemolysis equals Group B strep.
That's the one.
Why is this bacteria so particularly lethal to babies?
Again, it's the capsule. It's always the capsule with these guys. Group B has a polysaccharide capsule that is rich in sialic acid.
And why is sialic acid important?
Sialic acid is a potent inhibitor of the alternative complement pathway. Now, newborns, especially premature ones, have very low levels of complement to begin with, and they have no pre-existing maternal antibodies against this specific capsule type.
So their defenses are already down.
They're way down. So the bacteria enters the blood. The complement system can't tag it for destruction because of the sialic acid, and the white blood cells can't grab onto the slippery capsule. It just multiplies unchecked.
Where does the baby pick this up?
From the mother. It's vertical transmission. Group B strep is actually normal flora for many women. It colonizes the lower GI tract and the genitourinary tract in about 10 to 30% of healthy pregnant women.
It doesn't cause them problems.
Not usually. It usually doesn't bother the mother at all. Maybe a UTI or a postpartum endometritis. But during birth, as the baby passes through the birth canal, the infant can aspirate or swallow the amniotic fluid that contains the bacteria.
And this leads to the dreaded early onset disease.
Early onset is a disaster. It happens in the first 7 days of life, usually day 1 or day 2. The baby develops overwhelming sepsis, pneumonia, and meningitis. The mortality rate used to be incredibly high.
And then there's a late onset version too.
There is. Late onset is from about 1 week to 3 months of age. It's often meningitis, and it's usually caused by a specific strain, serotype 3. This can be from the mother, but it can also be from environmental sources like the nursery or other caregivers.
Because of this risk, we don't just wait and see. We have a massive public health screening program in place.
Absolutely. The screen and treat protocol, this is the standard of care in the U.S. and many other countries.
How does it work?
Every pregnant woman is screened at 35 to 37 weeks of gestation. We do a swab of the lower vagina and the rectum.
And just plate that.
We don't just put it on a plate. We put it in something called limb broth. This is a selective enrichment broth that contains antibiotics like nalidixic acid and colistin.
What do the antibiotics do?
They kill off all the normal flora, like E. coli, that would otherwise overgrow the plate. This allows the Group B strep, which is resistant to those antibiotics, to grow up to detectable levels.
So if a woman is positive, do we treat her right then and there at 36 weeks?
No. That's a really common misconception. If you treat her weeks before delivery, the bacteria will just grow back from the rectal reservoir. The colonization will return.
So when do you treat?
You treat intrapartum, during labor. The goal is to have high levels of penicillin G in the mother's blood and in the amniotic fluid while the baby is coming out.
So it protects the baby during transit.
Exactly. We want at least 4 hours of antibiotic therapy before the actual delivery. And this strategy has been incredibly effective. It reduces the rate of neonatal sepsis by nearly 100% in those cases.
Penicillin G is the drug of choice. What if she has a penicillin allergy?
It depends on the severity of the allergy. If it's a mild allergy, like just a rash, we can use cefazolin, which is a cephalosporin. It crosses the placenta well and works great.
And if it's a severe anaphylactic allergy?
Then we can't use any beta-lactams. We have to look at the bacteria's susceptibility patterns. We might use clindamycin if it's susceptible or vancomycin as a last resort.
Okay, that makes sense. Moving on to section 3, the other streps. We have group C and G, which Murray mentions are carried by Estes galactiae.
Right, and you can think of these as group A light.
What does that mean?
They can cause pharyngitis, just like group A. They can even cause post-infectious glomerulonephritis. But the key takeaway is that they do not cause rheumatic fever.
Another hard rule for the exams.
Absolutely. No rheumatic fever with C and G.
And then there's the Streptococcus aeruginosus group.
Right. These are technically part of the Viridans group, but they behave quite differently. They form these really tiny colonies on the agar plate, and they have a very distinct smell.
A smell.
Yeah, a kind of butterscotch or caramel odor. It's very characteristic.
And what's the clinical pearl for these guys?
The clinical pearl is abscesses. If you grow S. aeruginosus from a blood culture, you cannot just treat the bacteraemia and send the patient home.
You have to go looking for something.
You have to CT scan that patient. They almost certainly have an abscess hiding somewhere in the brain, the liver, the spleen. It just loves to form these deep, hidden pockets of pus.
Butterscotch abscess. I'll remember that. Now, let's talk about the proper Viridans group. S. mutans, S. mitis, S. salivarius. Viridis means green, so these are the alpha-haemolytics.
Yes, and they are the classic commensals of the mouth.
They're just part of our normal flora.
They are everywhere in your oral cavity, generally very low virulence, but they are highly opportunistic.
And lab-wise, how do we distinguish them from the other big alpha-haemolytic pneumococcus?
2 key tests. They are optogen resistant and bile insoluble. Pneumococcus is the opposite on both counts.
Okay, let's look at the specific associations. S. mutans. What's its claim to fame?
The dentist's nightmare. S. mutans is the primary cause of dental caries or cavities.
How does it do that?
It thrives on sucrose table sugar. It uses an enzyme called glucosyltransferase to take that sugar and turn it into these sticky, insoluble polysaccharides called dextrans.
And the dextrins are the problem?
The dextrin is the glue. It's the matrix of dental plaque. It allows the bacteria to stick tenaciously to the enamel of your teeth. Then they ferment the sugar, produce lactic acid, and that acid literally drills holes in your teeth.
Okay, so mutants and cavities. What about S. mitis?
This is the heartbreaker. This is the classic cause of subacute bacterial endocarditis, or SBE.
So paint the picture for us.
Imagine a patient who has a slightly damaged heart valve. Maybe they have mitral valve prolapse or a congenital bicuspid aortic valve. The blood flow over that valve is turbulent, not smooth, and this roughs up the surface, leading to little deposits of platelets and fibrin.
So it's a prepped surface.
It's a prepped surface. Now, that patient goes for routine dental cleaning. The gums bleed a little bit. S. mitis from the oral flora gets into the bloodstream. This is a transient bacteremia. It happens all the time.
Right.
But in this patient, because they produce those sticky dextrans, they can latch onto that damaged prepped valve surface. They start to grow there, very slowly, piling up into these structures we call vegetations.
And this is subacute bacterial endocarditis. It's subacute, meaning it happens over weeks to months, unlike the acute endocarditis from Staph aureus, which can destroy a valve in days.
Exactly. The patient presents with low-grade fever, fatigue, weight loss, maybe a new heart murmur. It's very insidious.
And the last one in this group is probably the most famous exam question of all time. S. bovis, which is now called S. galolyticus.
The canary in the coal mine for colon cancer.
Tell us about this association.
S. bovis is technically a group D strep, but not an enterococcus. It lives harmlessly in the gut of many people.
Okay.
But if you find S. bovis in a blood culture, there is a very, very high probability, some studies say over 50%, that the patient has an underlying colonic carcinoma or at least a large polyp.
How does that work?
The thinking is that the tumor, or the inflamed tissue, disrupts the mucosal barrier of the colon. It creates little ulcers or breaks in the lining, allowing this otherwise harmless gut bacteria to leak into the bloodstream.
So the bacteremia is a sign of a sick colon.
It's a huge red flag. The rule is, S. bovis in the blood means a mandatory colonoscopy. You aren't just treating an infection, you are actively screening for cancer.
Okay. Section 4. We are still in alpha-haemolytic territory, but this is no Viridans opportunist. This is a primary killer. Streptococcus pneumonia, the pneumococcus.
A major cause of death worldwide, especially at the extremes of age.
Let's start with the visual. Under the microscope, what does it look like?
It's a gram-positive diplococcus, so it's seen in pairs, but they are classically lancet-shaped. They look like 2 little candle flames touching at their bases.
And the lab differentiation from Viridans strep?
As we said, it's the opposite. Pneumococcus is bile-soluble. If you add bile salts, the colonies literally dissolve. And it is optogen susceptible. If you put a little paper P disc that's impregnated with optogen on the plate, you'll see a zone of inhibition. Pneumococcus dies.
Let's talk virulence. It seems like it's all about the capsule again.
The capsule is everything for pneumococcus. If you take a pneumococcus and genetically strip its capsule off, creating what we call a rough strain, it becomes completely avirulent. It cannot cause disease.
So it's an absolute requirement for pathogenesis.
It is. And there are over 90 different serotypes of these polysaccharide capsules. They're slippery, they have a negative charge, and their main job is to prevent phagocytosis.
This leads to that historical test, the quelling reaction.
Right. It's not really done clinically anymore, but it's a great concept. You mix the bacteria with specific anti-serum that contains antibodies against that particular capsule type. If the antibodies bind to the capsule, it causes the capsule to swell and become much more refractile, more visible under the microscope. Quelling is the German word for swelling.
So the capsule swells up. What else is in the pneumococcal toolkit?
It has an IgA protease. Since it lives in the nasopharynx, it needs a way to deal with our mucosal immunity, which is primarily secretory IgA. So it just produces an enzyme that chops the antibody in half.
Disarms the local security.
Exactly. And then it has pneumolysine. This is a cytotoxin. It binds to cholesterol in host cell membranes, and it punches holes in them, like a little hole punch.
And what cells does it target?
It specifically destroys the ciliated epithelium of our respiratory tract. It basically stops the mucociliary escalator that's constantly working to clear mucus and debris out of our lungs. By stopping that escalator, it allows the bacteria to descend from the nasopharynx down into the lungs.
Which leads, not surprisingly, to pneumonia.
Classic lobar pneumonia, a textbook presentation.
What does that look like?
The patient presents with a very sudden onset of a shaking chill, what we call a rigor, and a high fever. They start to cough up sputum. But it's not fresh red blood. It's classically described as rusty sputum.
Why rusty?
That color comes from red blood cells that have leaked into the alveoli, been length by that pneumolysine we just talked about, and the hemoglobin has been oxidized. It's basically alpha-haemolysis happening inside your lung. It looks like rust.
And on a chest x-ray?
You'll see a solid whiteout of an entire lobe of the lung, a dense consolidation.
The mnemonic for pneumococcus diseases is a classic one, MOPS.
A very useful one. M is for meningitis. It is the #1 cause of bacterial meningitis in adults and the elderly. O is for otitis media. It's the #1 bacterial cause of middle ear infections in kids. P is for pneumonia, as we just discussed. Lobar pneumonia.
S.
S is for sepsis. And this is particularly a problem in splenic patients.
Why is the spleen so critically important for fighting this specific bug?
The spleen is our body's specialized filter for removing encapsulated bacteria from the bloodstream. Opsonized bacteria coated with antibody and complement get trapped in the unique architecture of the spleen and eaten by resident splenic macrophages.
So if you don't have a spleen...
If you don't have a working spleen, like patients with sickle cell disease who auto-infarct their spleen, or patients who've had a splenectomy after a trauma, you have lost that critical filter.
And the pneumococcus just runs wild.
They're at massive risk for fulminant pneumococcal sepsis. They can go from feeling fine to being dead within a matter of hours. It's why they need prophylactic penicillin and very rigorous vaccination schedules.
Okay, let's clarify the vaccines. This is a topic that's often confusing for students. We have PTSV23 and PCV13. Why are there two different vaccines?
It all comes down to the immunology of sugars versus proteins.
Go on.
The capsule, the thing we want to make antibodies against, is a polysaccharide. It's a pure sugar.
Right.
Sugars are what we call T-cell independent antigens. B cells can see them and make some antibodies. But T cells, the helper T cells that are critical for a strong immune response, they don't recognize sugars. They only recognize peptides, which are proteins.
So without T-cell help, what happens?
Without T-cell help, the B cells make a weak IgM response. And critically, they do not form memory B cells. There's no long-term immunity. And this response is particularly terrible in children under the age of 2. Their immune system just pretty much ignores pure sugars.
So the old vaccine, PPSV23, which is called Pneumovax, is just a mix of the sugar from 23 different strains.
It's functionally useless for babies. We still use it for adults over 65 because their mature immune system can handle it to some degree, but it doesn't create lasting mucosal immunity or immunologic memory.
So how do we protect the kids? This is a huge cause of disease in kids.
We use a very clever biological trick. We use a conjugate vaccine, which is PCV13 or Prevnar.
How does that work?
We take the sugar from the pneumococcal capsule and we chemically tie it or conjugate it to a protein. In this case, it's a non-toxic mutant version of diphtheria toxin.
And what does that do?
The B cell, which recognizes the sugar part, eats the entire sugar protein complex. It then processes the protein part and presents it on its surface to a T cell.
So it shows the T cell something it can recognize.
Exactly. The T cell sees the protein and says, aha, a protein, I can help with this. The T cell then provides powerful help to the B cell, which causes class switching from IgM to high-affinity IgG, and most importantly, the formation of long-lived memory B cells.
So you're tricking the T cells into helping with an anti-sugar response. That is such an elegant biohack.
It's one of the great triumphs of modern vaccinology.
Okay, final section before we test ourselves. Enterococcus, the survivors.
Formerly known as Group D strep. Now they have their own genus, The two big players are E. faecalis, which is more common, and E. faecium, which is more dangerous and more resistant.
And these bacteria are tough.
They are incredibly tough. In the lab, they grow in the presence of bile, just like other group D strep, but they also grow in 6.5% ACL. That's very high salt.
Most bacteria can't handle that.
Most streps would die instantly in that much salt. Enterococcus thrives. They're also PYR positive, just like group A strep.
So if you have a PYR positive bug, you check the hemolysis. If it's beta hemolytic, it's group A strep. If it's gamma or non-hemolytic, it's likely Enterococcus.
Precisely. That's a great way to think about it.
Clinically, is Enterococcus an aggressive invader like group A?
No, not at all. It's an opportunist. It's primarily a nosocomial pathogen, a hospital-acquired infection. I think of it as the cockroach of the hospital.
Why a cockroach?
It just persists. It survives on bed rails, on healthcare workers' hands, on equipment. It's very hard to get rid of. And it targets patients who are already sick, especially those with foreign bodies.
Like what?
1, UTI. It's a major cause of catheter-associated UTIs. 2, peritonitis, especially in mixed infections after abdominal surgery where there's been a gut spill. And 3, endocarditis, a subacute form that's very difficult to treat.
And the big story with Enterococcus, the thing everyone worries about, is resistance.
They are naturally intrinsically resistant to a whole class of antibiotics, the cephalosporins. You can't use ceftriaxone. They also have low-level intrinsic resistance to aminoglycosides.
So how do you kill them?
To get a bactericidal effect, you usually need synergy. You combine a cell wall agent like ampicillin or vancomycin to punch a hole in the wall. This allows the aminoglycoside, like gentamicin, to flood into the cell and shut down the ribosomes.
But the real nightmare is when they become resistant to vancomycin itself, VRE.
Vancomycin-resistant enterococcus. A huge problem in hospitals.
How does VRE beat vancomycin?
It's another molecular disguise, a brilliant and simple one. Normally, the bacterial cell wall is built from peptide chains that end in the sequence D-alanine.
Okay.
Vancomycin works like a baseball mitt that specifically catches that D-Ella ball. It binds to it and covers it up, preventing the enzymes from cross-linking the wall. The wall falls apart.
So how does VRE get around that?
VRE acquires a gene cluster, often the VAN gene, that tells the cell to change the recipe. Instead of making D-Ella at the end of the chain, it makes D-alanine D-lactate.
It just swaps one alanine for a lactate?
Exactly. It's a tiny chemical change. It swaps an amino group for a hydroxyl group. This removes a single hydrogen bond that vancomycin needs to bind effectively.
And that's enough.
That's enough. The vancomycin mitt cannot grab the D-Ella D-lactate ball. It just slips right off. The drug is rendered completely useless.
D-Ella D-lac. That's the molecular code for high-level vancomycin resistance. So what do we use to treat VRE?
We have to pull out the heavy hitters. We use drugs like linezolid, which is a protein synthesis inhibitor, or daptomycin, which is a membrane disruptor.
We have covered an immense amount of ground, from the throat to the heart, the birth canal to the meninges, and from the hospital floor to the colon.
It's a very diverse group of organisms.
Let's lock this all in with our rapid recall. I'm going to give you a clinical scenario. I'll pause for a moment to let you at home think. Then our expert will break down the answer.
Let's do it.
Question 1. A 7-year-old child presents with a bright red rough rash that feels like sandpaper. He has a strawberry tongue and a fever. A throat culture reveals gram-positive cocci in chains that are beta hemolytic. Which specific toxin is responsible for this rash?
The answer is streptococcal pyrogenic exotoxin, SPE types A, B, or C. This is the clinical picture of scarlet fever. The toxin is acting as a superantigen, causing that massive systemic cytokine release that leads to the characteristic rash and fever.
Okay, question 2. You are reviewing a plate in the microlab. You see a beta hemolytic colony. You aren't sure if it's group A or group B strep. You perform a PYR test and it turns a bright red color, which is positive. Is it group A or group B?
It is group A strep S. pyogenes. The key differentiators are that group A is PYR positive and it's sensitive to bacitracin. Group B is the opposite, PYR negative and bacitracin resistant.
Excellent. Question 3. A 65-year-old patient is admitted with symptoms of subacute endocarditis. Blood cultures grow Streptococcus galliticus, which is the new name for S. bovis. Besides starting antibiotics, what is the next mandatory step in this patient's management?
The next step is a colonoscopy. You absolutely must screen this patient for colonic carcinoma. The association is so strong that skipping this step could mean missing a life-threatening cancer diagnosis.
Critical point. Question 4. A newborn develops meningitis on day 3 of life. The mother was not screened for group B strep during pregnancy. The bacteria is isolated from the baby's CSF. Which specific component of the bacteria is primarily responsible for preventing the neonatal alternative complement pathway from activating?
That would be the sialic acid moiety of the polysaccharide capsule. Sialic acid is known to degrade C3b and inhibit the alternative pathway, which is a crucial arm of the innate immune system for a newborn.
Right. Question 5. Why is a pneumococcal vaccine given to infants, PCB13, conjugated to a protein, whereas the vaccine typically given to adults, PPSV23, is not?
To recruit T cell help, infants cannot mount an effective or lasting immune response to T-independent antigens, which are pure polysaccharides. By conjugating the sugar to a protein, you engage T helper cells, which allows for class switching from IgM to IgG, and most importantly, the development of immunologic memory.
Perfect. Question 6. A patient has impetigo, those honey-crusted skin lesions, caused by group A strep. 3 weeks later, they develop hypertension and dark Coca-Cola-colored urine. Could this patient also develop rheumatic fever from this same skin infection?
No, absolutely not. This patient has acute glomerulonephritis, AGN, which can follow either a skin infection or a throat infection. However, rheumatic fever follows pharyngitis only. The skin route does not lead to rheumatic heart disease.
Last one. Question 7. An isolate of Enterococcus from a hospital outbreak is found to be resistant to vancomycin. DNA sequencing reveals the presence of the VAN-A gene. What is the specific biochemical result of this gene's expression?
The cell wall precursor changes from D-allo-DL to D-allo-D-lactate. This single amino acid substitution prevents vancomycin from being able to bind to its target in the cell wall terminus, rendering the drug ineffective.
How do you do out there? The key with strep and enterococcus is to link the look, the hemolysis, the chains with the weapon, the M protein, the capsule, the toxins, and the disease, pharyngitis, meningitis, endocarditis.
Exactly. Don't just memorize the list of facts. You have to understand the chess match. Group A tries to hide with hyaluronic acid. Group B stops complement with sialic acid. Pneumococcus shields itself with its 90-plus sugar capsules. The host fights back with antibodies, but then sometimes those antibodies cross-react and attack the heart, like in rheumatic fever, or they clump up and clog the kidneys in AGN.
It's a fascinating dynamic. So, a final thought before we close the incubator for today. We talked about rheumatic fever being largely a disease of the past in the developed world, but it's still rampant in many developing nations. The bacteria, S. pyogenes, is the same. Its genetics haven't changed that much. It makes you wonder, is the decline in the West purely due to our widespread use of antibiotics for sore throats? Or has there been a fundamental shift in the imprinting of our immune systems because we live in cleaner environments? Or is it some combination of factors? The bug is a constant, but the host pathogen equation is always shifting its variables.
The chains of infection definitely bind us to our history, and they aren't going anywhere.
Thanks for diving deep with us. Go back and review those hemolysis photos in Murray Chapter 19. They're incredibly helpful. We will see you on the next slide.
Goodbye.